us. And now we'll present our next speaker. We have Dr. Abhidha Shah. She's a physician and consultant neuro and endovascular surgeon and assistant professor at Seth JS Medical College and Kim Hospital. Dr. Abhidha will talk today about the anatomy of the cavernous sinus. Dr. Abhidha, how are you?
I'm fine, Dr. Ahmed, and thank you for this invitation. Very nice lecture, Eduardo. Beautiful depiction of the meninges.
Thank you. I'm going to stick around to learn about the cavernous sinus because this is a very complicated region, and it's always nice to see some update and refresh.
So, should I start, Ahmed?
Yes, please. Yes, please, doctor. You can start.
Okay. So now you've seen the anatomy of the dural layers. So to understand the anatomy of the cavernous sinus, the first important thing that you have to learn is these dural folds that form the cavernous sinus. So let's look at the bony anatomy first, then we'll see the dural anatomy, and then we'll go into the actual cavernous sinus. So the cavernous sinus is a real inner place at the base of the skull, and it is a very important location, and it helps in maintaining homeostasis of the region because it is directly, intimately connected with the sphenoid sinus in this region, which gives it all the information of the outside world. So it communicates with the outside world on the basis of the air in the paranasal sinuses. So there are some important bony landmarks you must understand before you go into the core anatomy of the cavernous sinus. One is this bony prominence, that is the anterior clinoid process. This one here, there is a bone that is running from the base of the anterior clinoid process right up to the sphenoid sinus, and it separates this optic canal from the superior orbital fissure, and that is the optic strut. This is the lateral part of the sphenoid sinus. You see this groove here, that is the carotid sulcus, which houses the internal carotid artery. Here you see some openings. So this one is the superior orbital fissure. This one is the foramen rotundum. This one is the foramen ovale. And here you see this one is the foramen lacerum, through which the internal carotid artery enters. This is the body of the sphenoid bone. Here you can see the tuberculum sellae, the dorsum sellae. This is the posterior clinoid process. This is the petrous apex. Some of these things you've already seen. This is the cribriform plate. So now this portion of the bone in the middle skull base is what is important for understanding the relation of the cavernous sinus. So the cavernous sinus is this boat-shaped area as described by Professor Roton. So you see this blue structure here, that is the cavernous sinus that lies in this inner part of the middle fossa. So it is anteriorly related to this anterior clinoid process and this optic strut that we just saw. And this portion is related to the lateral part of the body of the sphenoid sinus. Now this cavernous sinus is a venous plexus. Whether it is plexiform, whether it is just a bunch of veins, there is a lot of confusion in the literature. But to understand it, you have to understand that it remains within some dural folds. So as Dr. Eduardo was explaining, there are two layers of dura. There is a layer that runs over the bone, that is the endosteal layer, and one layer of the dura runs in close connection with the pia and the arachnoid, and that is the meningeal layer. So this yellow thing here that you see is the meningeal layer of the dura, and this orangish pinkish thing that you see is the endosteal layer of the dura. Now within these two layers, so in the middle fossa, this part of the meningeal layer and this part of the endosteal layer, they split. And within this split of the dura lies the cavernous sinus. Now it's not as simple as this. There are still more intricacies in this. So first, basically, you understand that there is a split in this meningeal and endosteal layer. There is a further split in the endosteal layer, and one layer forms the inferior wall, inferior base of the cavernous sinus, and one layer forms the medial wall of the cavernous sinus. And within this lies the venous plexus. Now, what is this inner ring that I have drawn here? And this is the part of the dura and arachnoid that runs with the cranial nerves. So this is the meningeal layer. And once you peel this layer, you will see this layer of the dura that runs with the cranial nerves and fuses with this endosteal layer. And that is your inner layer of dura of the lateral wall of the cavernous sinus. So these are the dural layers within which the cavernous sinus resides. So let's look at this again. So this is the endosteal layer Here the meningeal layer has been removed. And here you see the beginning of the cavernous sinus. So the outer wall of the dura is removed here. The inner wall of the dura here is made up of this endosteal layer mixed with the layer of dura that surrounds the cranial nerve. So you see the fifth cranial nerve with its dura entering here and forming the lateral part of the cavernous sinus. Here you see the roof of the cavernous sinus where the oculomotor nerve also has a sheath of dura and arachnoid forming the roof of the cavernous sinus. And this is where the cavernous sinus lies. Here you see that it is communicating posteriorly with the basilar plexus. So now let's look at it from a coronal aspect. So you see this layer that you see here is the meningeal layer that runs in close connection with the cerebral surface. And this layer that is coming down here is the endosteal layer. So here you have a meningeal layer and you have an endosteal layer. Now you see this endosteal layer is fused with this. These are the cranial nerves in the lateral wall of the cavernous sinus. So the dura of these nerves is fused partially with this endosteal layer, and that forms the inner wall of the lateral wall of the cavernous sinus. And all the venous plexus is beyond this lateral wall. So pathologies of the cavernous sinus that arise from this lateral wall and remain within this interdural compartment will not bleed, because the venous plexus, as you can see here, where the dura has been removed, the venous plexus is more medial to this, and within the cavernous sinus lies the carotid artery. So this is the relation of the dura. And as someone was asking about the roof of the cavernous sinus, so the roof of the cavernous sinus is a continuation of this dura that is on the planum sphenoidale and the tuberculum sellae. It actually runs laterally and curves downwards when it forms the inner wall of the lateral wall of the cavernous sinus, and that is the roof of the cavernous sinus. And within it, there are folds of the clinoidal ligaments, as I will show you in further images. So you see in this coronal cut, this is the sphenoid sinus. Here, there is a sinus that connects both the cavernous sinuses. There is one anteriorly and one posteriorly. The posterior intercavernous sinus is the bigger one, and this is the anterior intercavernous sinus. And of course, this is the carotid artery. So to understand the pathology of lesions in the cavernous sinus, it is better to understand the cavernous sinus into these three compartments. One is a compartment which is just outside the cavernous sinus but touching its lateral wall. So you see this pink compartment here. So there are lesions that will arise from this part. The second one is this interdural compartment, this blue one here, where it involves these cranial nerves and the walls of the dura in this region. The third one is this inner compartment, which is the actual compartment of the cavernous sinus. And there are pathologies that are present in this inner part of the cavernous sinus, which we will discuss as the presentation goes. So this is the inner sanctum of the cavernous sinus, and the most medial relation of the cavernous sinus, of course, is the pituitary gland within the sella. So as we have the circle of Willis for the arteries, this cavernous sinus, Professor Goel and Professor Kothari call it, is the venous circle of relief. So what happens is there is an anterior and a posterior intercavernous sinus which communicate with each other. So if there is blockage in one part, the cavernous sinuses actually, because of these collaterals and because of this circle, actually equalize the pressure. And this works it has a big role in eye movements and in neutralizing the pressure over both the eyes. And that is why it is called the venous circle of relief. Another important anatomical point of the cavernous sinus is it has a counterpart in the neck, which is completely similar to this. So if you see the cavernous sinus here, it has the trigeminal ganglion, it has the internal carotid artery, and it has a huge venous plexus. Similarly, if you see in the neck, you see there is a C2 ganglion, there is the vertebral artery, and then there is a venous plexus surrounding the vertebral artery and the C2 ganglion. So the cavernous sinus has a counterpart in the neck around the vertebral artery, and pathologies of some of these are very similar. Like the trigeminal neurinoma has a very similar pattern of growth as compared to a C2 neurinoma. But of course, that is a different topic. And this is just an anatomical point that you would like to know. Now, coming back to the cavernous sinus. So this is a cadaveric specimen that you can see, showing you all the nerves that are present in the roof and the lateral wall of the cavernous sinus. And there is a dural layer that is covering this. So this is the inner layer of the wall of the cavernous sinus. The outer meningeal layer has been peeled off. And now let's peel this layer one by one to understand the anatomy of the cavernous sinus and its contents. So let's start with the roof. So here you see, this is the optic nerve. This is the internal carotid artery. Here you see that this is the anterior clinoid process. Now there are two folds here, and within these folds is the oculomotor triangle. So here you see the oculomotor nerve is entering into this oculomotor triangle, which is formed by the anterior petroclinoidal fold, posterior petroclinoidal fold, and the interclinoidal fold. Also in the lateral aspect of this oculomotor triangle or the roof of the cavernous sinus, the trochlear nerve enters. This is a very important surgical corridor. The oculomotor nerve has a cave of, sheet of CSF around it in its arachnoid that is known as the oculomotor cave or oculomotor cavern, where in which the oculomotor schwannomas can arise from, and you can approach the tumors in this region. Medially, here you see the pituitary gland with the stalk. Here you see the beginning of some venous plexus in the cavernous sinus. Now, the roof of the cavernous sinus houses two triangles. Now, as the parts of the cavernous sinus have been divided into various triangles just to understand its anatomy and just to understand various surgical corridors through which you can enter into the cavernous sinus. This anatomy is distorted by the pathology, but because it has fixed points, you can identify at least the entry point of these triangles if you want to operate on the cavernous sinus. So this yellow triangle that you see here is the clinoidal triangle, here, which is formed by the anterior clinoid process, and it lies between the optic and the oculomotor nerve. So this is the optic and this is the oculomotor nerve, and this is the clinoidal triangle. So if you remove the anterior clinoid process, you will enter into this clinoidal triangle. The next one that you see here is the oculomotor triangle, which is formed by the anterior and posterior petroclinoid folds and the interclinoid fold. In this, the contents of the oculomotor triangle is the oculomotor nerve, and in the lateral aspect of the oculomotor triangle, the fourth nerve enters also into the roof of the cavernous sinus. So it runs, the fourth nerve runs lateral to the oculomotor nerve and then crosses it when it crosses the superior orbital fissure. So here you see the triangle more nicely. Here you see the folds, the anterior and the posterior petroclinoidal fold and the interclinoidal fold. As you can see how Dr. Eduardo described, this is the free edge of the tentorium. So this dural leaflet also merges with these folds and also actually splits to form this anterior and posterior petroclinoidal folds, as you can see very clearly in this cadaveric image. So here again, let's see, this is the outer layer of the dura peeled off. This is the inner layer of the dura. You cannot see any cranial nerve right now because there is this inner layer of the dura that is still present. This is the roof of the cavernous sinus. This is the posterior part of the cavernous sinus. And here you can see that the cavernous sinus communicates directly with the basilar venous plexus. So now here the posterior wall of the cavernous sinus has been removed. Here you see the sixth nerve is now entering into the cavernous sinus. And this ligament here that you see is the Gruber's ligament, beneath which the sixth nerve will enter. So here now the roof of the cavernous sinus has been opened and you see the oculomotor nerve in its entirety. You see the fourth nerve as it is entering into the roof of the cavernous sinus. Here you see the dural layers. So as I said, this is the endosteal layer and this is the layer that continues over the roof of the cavernous sinus. This is the posterior part of the clivus. Here you see some arteries, which we will see when we are seeing the internal carotid artery. But these are clival arteries and meningeal branches which supply the clivus. So here you see the roof of the cavernous sinus once again, the oculomotor nerve, the trochlear nerve, which are the important relations of the roof of the cavernous sinus. Now you see that one layer of the dura here has been peeled off. And you start seeing the fifth cranial nerve. So you start seeing the fibers of the fifth cranial nerve as you remove the epineurium or the dura over the inner wall of the lateral part of the cavernous sinus. Now on the posterior aspect, so we saw the roofs on the triangles on the roof of the cavernous sinus. There are two triangles that are present on the posterior wall of the cavernous sinus. And these are the inferolateral and the inferomedial triangle. Now here this triangle, the inferolateral triangle, is formed by a line that is joining the fourth entry of the fourth cranial nerve and the sixth cranial nerve. You can see this line. And then it is formed by two lines that run here and join where the first petrosal vein joins the superior petrosal sinus. The most important content of this is the trigeminal nerve with its ganglion as it enters into the Meckel's cave and enters into the lateral part of the cavernous sinus. The second triangle here is again formed laterally by these entry points of the fourth and the sixth cranial nerve by this line, and then medially by this clival portion of the dura that is present here. And the content of this triangle is the abducent nerve as it passes beneath the Gruber's ligament. So this is the posterior aspect of the posterior wall of the cavernous sinus. Now again, this has been removed. Here you see the contents nicely. Now you see the fifth nerve that is entering. Here you see the ganglion, and here you see the branches of the fifth nerve as it is entering the lateral part of the cavernous sinus. Now you see the carotid artery also coming into view. So now the venous plexus of the cavernous sinus can also be seen in relation, or can be divided in relation to the carotid artery as medial, lateral, superior, and inferior. Basically, all of them connect either by the superior ophthalmic vein. It drains, that is the major sub-drainage of the cavernous sinus, or it drains through the sylvian veins, or it drains through the pterygoid plexus down into the infratemporal fossa, or it drains through the basilar plexus. And of course, there are two connections, that is the anterior and the posterior intercavernous sinuses. So again, now the roof is unroofed. You see the third, fourth, and you start seeing the fifth that is coming into view. Now we'll come from laterally. So we've seen the roof of the cavernous sinus. Now let's see the lateral part of the cavernous sinus. So the meningeal layer again has been peeled, and now this is the inner layer of the lateral part of the cavernous sinus. And once you incise this layer, you will see the cranial nerves. So the cranial nerves are in the interdural compartment of the cavernous sinus. So this is an image from Roton's collection. And here you see the ganglion and how it is dividing into the three roots. And you see that there are various connections between these fibers. So it's like kind of like a plexiform anastomosis. And in this region, this is the region of the Meckel's cave. And this is the dural leaf that once you incise, you will see the cranial nerves. Here you see the internal carotid artery as it is entering from the foramen lacerum into the cavernous sinus. So now you see that the whole dural layer has been peeled off. And here you see the whole trigeminal nerve with its divisions. Here you see the tentorial free edge as it is running and forming the petroclinoid fold. Now you see the components here. So let's see again the optic nerve, the internal carotid artery, the anterior clinoid process, the oculomotor nerve. The fourth nerve will be running right here. Now here you have the V1 as it is entering into the superior orbital fissure. You have the V2 as it is entering into the foramen rotundum, and the V3 as it is entering into the foramen ovale. So basically the V1 and V2 form the lateral part of the wall of the cavernous sinus. The V3 exits from the back of the cavernous sinus and is actually not a component of the lateral part of the wall of the cavernous sinus. And this vessel that you see here is the middle meningeal artery. Now you see the posterior part of the cavernous sinus connects with this sinus, and that is the superior petrosal sinus that is running on the superior surface of the petrous bone. So this is the lateral perspective. Now let's again peel layer by layer. So here you see the oculomotor. The specimen has been turned a little bit. Here you see the V1, the V2. So the ophthalmic, the maxillary, and the mandibular division of the trigeminal nerves as they are entering into their respective foramen. Here you see the innumerable connections that these nerve fibers have been within each other and within the ganglion. Now when you lift the V1, you start seeing this nerve. This is the abducens nerve. So the abducens nerve, as you see, entered beneath the Gruber's ligament and runs on the lateral aspect of the carotid artery posteriorly and then becomes inferolateral to the carotid artery. So this is not seen directly from the lateral wall. So this is the inner compartment of the cavernous sinus, and you start seeing the venous plexus here. And when you lift V1, you will see the sixth cranial nerve coming into view. And once you lift this when you lift this ganglion down, and you will see the venous plexus as it is connecting into the basilar plexus. And here you see the branches of the internal carotid artery. So the Gaussian ganglion has been retracted downwards, and you see the posterior part of the cavernous sinus wall. And here the sixth nerve will make its entry. Now the venous plexus of this region has been removed, and you start seeing the carotid artery coming into picture here. Now the carotid artery, as it enters the cavernous sinus, it enters the cavernous sinus from the foramen lacerum, which I showed you. So as it enters the cavernous sinus, it is fixed at this point where there is a dural fold that connects that runs over the superior surface of the carotid artery. And there is another dural fold here, that is the carotid collar or the upper dural ring, that fixes the carotid artery near the anterior clinoid process. But the whole segment of the carotid artery between these two folds is relatively free and mobile, and it is divided into various segments. So this is the posterior ascending segment. This is the posterior genu. This is the horizontal segment. This is the anterior ascending segment. This is the anterior genu, and this is the supraclinoid part of the internal carotid artery. So this is how the carotid artery runs, and this is the dural fold. So the upper and the lower dural ring. Here you can see that this dural ring is closely adherent to the wall of the carotid artery, whereas this part is not very adherent, and sometimes there is venous plexus in this region. So as you drill in this region, you will have a lot of venous bleeding. And this region here is also called the carotid collar, which if you drill the ACP and if you open this region, you will be entering into this region to see the anterior genu of the cavernous of the carotid artery and the supraclinoid part of the carotid artery. Now the lateral wall of the cavernous sinus also has various triangles. So you see this one here, this is the supratrochlear triangle that runs between the oculomotor and the trochlear nerves. This one is the most important or the most noteworthy triangle of the cavernous sinus, and that is the Parkinson's triangle. It was described by Dwight Parkinson, and it is between the trochlear and the V1 nerve root, and a line joining the entry points of these two into the cavernous sinus. And what is the importance of this triangle? If you incise and enter into this triangle, it gives you exposure to the carotid artery and its meningohypophyseal trunk. So Parkinson used this approach for treating caroticocavernous fistula. When there was no endovascular embolization available, you could enter into this route and treat CCF from this region. You have two more triangles here, the anterolateral and the anteromedial triangle. So the cavernous sinus per se has these four triangles, the two in the roof, that is the clinoidal and the oculomotor, and this one, the supratrochlear and infratrochlear triangle. In the middle fossa, there are four triangles. So the anteromedial, the anterolateral triangles. The anteromedial runs between the V1 and the V2 here. If you drill in this region, you will enter into the sphenoid sinus. Similarly, this is between the V2 and the V3. If you drill into this in this region, you will enter into the lateral aspect of the cavernous sinus. So these are the triangles on the lateral wall of the cavernous sinus. And in the middle fossa, also there are two more triangles, the posterior medial and the posterior lateral triangle. The most important here, the landmarks are the posterior border of the V3 and the GSPN, which you can see here running here. And this is the posterolateral triangle, whose most important constituent is the middle meningeal artery. And this one, as we all know, is the famous Kawase triangle, which gains you access into the posterior fossa if you drill in this region. So these are the triangles on the lateral wall of the cavernous sinus and also in the middle fossa. Now we have depressed the fifth cranial nerve, and you start seeing this carotid artery. So you see, this was the dural fold that I was talking about, and that is the fixed segment of the carotid artery. And then this is the mobile segment. So as soon as it comes into the cavernous sinus, from the posterior genu or posterior aspect, there is a major branch of the cavernous carotid, and that is the meningohypophyseal trunk, as you can see here. Immediately as it emerges, it divides into multiple branches. One is the tentorial artery of Bernasconi-Casanari, and it goes on to supply the tentorial dura. Other one is the inferior hypophyseal artery, and it goes on to supply the pituitary gland. And the last one are these meningeal branches or the dorsal clival arteries that go on to supply the clival dura. It anastomoses with its counterpart on the other side, and it forms a rich network of meningeal supply here. So this is a view from the top where you see the horizontal segment of the cavernous carotid running in this curved-like fashion and coming to the region of the carotid collar. So here, this is the posterior image of this meningohypophyseal trunk showing its branches. So the tentorial artery, the dorsal clival arteries, and the inferior hypophyseal artery. There is another branch of the carotid, that is the inferolateral trunk or the artery of the inferior cavernous sinus, that goes on to supply the dura. Now we were seeing all these from a microscopic perspective. So we have seen the entire cavernous sinus from a microscopic perspective, where you saw the roof, the lateral part of the cavernous sinus, the posterior wall of the cavernous sinus. You saw the contents of the cavernous sinus, that is the carotid and the sixth cranial nerve, and then the medial relation of the carotid of the cavernous sinus, and that is the pituitary gland and the stalk. And this is the posterior part of the cavernous sinus. If you look at it from an endoscopic perspective, then this is what you will see. This is the anterior view. You see the cavernous carotid here. You see some branches that are directly going on to supply the capsule of the pituitary gland, and that is McConnell's capsular artery. This is the pituitary gland. This is the ligaments of the pituitary gland which run towards the carotid artery, and this is the medial wall of the cavernous sinus, which is very weak and sometimes dehiscent, through which these pituitary tumors can enter into the region. Now some dissection more has been carried out, and you can see the whole course of the carotid artery. I will not go into this detail. I'm just showing some images. This is the Vedian nerve as it is coming down. It is an important landmark for endoscopic surgery. Here again, you see the McConnell's capsular artery as they supply the capsule of the pituitary gland. Here you see the venous plexuses around the carotid artery. And once you retract the carotid artery, you will see these various nerves. So this is the sixth cranial nerve. This is the V1. This is the V2. There are sympathetic nerves that surround the carotid in its course and form a sympathetic plexus. Here now, once you retract it more medially and see superiorly in the roof, you will see the third cranial nerve. So from the anterior aspect, this is how the cavernous sinus looks. Now coming back to the lateral wall. So these are the various triangles that we saw. The oculomotor, the supratrochlear, the infratrochlear, the anteromedial, anterolateral, posterior medial, posterior lateral, and the triangles on the back of the cavernous sinus. Now, how does all this apply clinically? So quickly, I will show you some tumors of the cavernous sinus and how understanding the compartmental anatomy of the cavernous sinus will give you an understanding of these tumors. So this is just an overview where you see all the nerves with all the venous plexuses in this region. So here you again see the third, the fourth, the fifth cranial nerve, and all of them running here. This is the carotid artery as it is coming out from the foramen lacerum. This is the region of the posterior fossa. Again, this is the semicircular canals and the cochlea. This is the facial nerve and its genu with the geniculate ganglion, the GSPN coming out. So all this is part of another lecture, but this is just to give an overview. Now let's coming back to these compartments of the cavernous sinus and their relation to pathology. So as I said, this is one compartment. This is the interdural is the second compartment, and this is the inner compartment of the cavernous sinus. So my mentor is Professor Goel, and as you can see that he has done a lot of work on the cavernous sinus, and all of my understanding is based on this work. So this is two important things for understanding tumors in the cavernous sinus is understand how the tumors displace the cavernous carotid artery. And that gives you an avenue, an understanding of what approach you should take to reach these lesions. And the second thing is understanding the dural layer of the cavernous sinus and how it will protect you during surgery. So the first important thing you learn is the extradural approach to lesions involving the cavernous sinus. So all the tumors that are in the lateral aspect or in the interdural compartment or in the inner compartment, majority of them can be approached by this extradural approach to lesions of the cavernous sinus. Quickly, let's look at it. So this is a lateral view of the skull. This is the extent of the craniotomy that has to be performed. This is the zygomatic arch. On the lateral position, sometimes we give a lumbar drain or lumbar puncture so that the brain becomes lax. Then this is the peeling of the meningeal layer. This image is from Roton. This is the middle meningeal artery. This is the first important structure that has to be cut. So you will coagulate it and ligate it. Once you do that, it becomes easy to peel the layer of the meningeal layer and reach the inner wall of the cavernous sinus. And once you do that, you will see the inner layer here also has been removed, and you will start seeing all the structures, and then you can decide your point of entry into the cavernous sinus. So the V1, V2, V3, the carotid artery that you can see here, this is the tentorial fold, this is the third nerve, and this is the fourth nerve. So again, once you peel it, then this is the area that you will drill to enter into the posterior fossa, and that is the Kawase triangle. So this is the approach you can get by the subtemporal approach. Now let's look at some pathologies quickly. So see this tumor that is arising just touching the lateral wall of the cavernous sinus. This is the meningioma of the lateral wall of the cavernous sinus, relatively straightforward to do. This is just the attachment that has to be coagulated in this region. There is not too much venous bleeding from inside the cavernous sinus, and it will not hamper your surgery. This is a meningioma of the anterior clinoid process, also involving the lateral wall of the cavernous sinus. As you can see here, again, this is eminently resectable and does not need to undergo any kind of radiosurgery. This is a tumor that is again of the anterior clinoid process, and it is, of course, you have to take care of these vessels that are within the tumor, but you can eminently remove this tumor without any problem. This is again a tumor of the anterior clinoid process, and here you can see that the lateral part, it is involving the lateral wall of the cavernous sinus, and it has to be excised in that manner. This is a tumor involving all the layers of the cavernous sinus, entering into parts of the cavernous sinus. So here you see this part of the tumor has been removed. This posterior fossa part of the tumor has been removed, but some tumor in the cavernous sinus where it has invaded the sinus can of course be left behind. And if necessary, generally it remains stable. If it grows, it can be given radiosurgery. So that is the meningiomas that arise from the dura of the cavernous sinus. The next thing that you have to know is the second layer, the interdural layer. And this is where the trigeminal neurinoma comes on from. So you see how the branches of the fifth nerve are present in this interdural compartment, and the trigeminal nerves follow this route of the trigeminal nerve. So sometimes they are only in the middle fossa, sometimes they are only in the posterior fossa, and sometimes they take this dumbbell shape extension when they arise from the ganglion and then go anteriorly and posteriorly. Sometimes they have an extracranial course. So there are 4 types of trigeminal schwannomas, and the interdural approach to trigeminal schwannomas was described by Professor Goel. And he has also described saving of the fifth cranial nerve so that there is preservation of function and improvement of function. So you see, we are using this approach to reach trigeminal ganglion neurinomas and remove them. So this is again pre-op and post-operative image. So this is just to show you some beautiful cases. So this is a neurinoma that is going around the ophthalmic division. You see how it follows the trajectory of the V1. This is a neuronoma that is arising from the V2 division of the maxillary, and it is going all the way down. So you see how it follows the course of the nerve. This is a tumor that is going through the foramen ovale, a tumor of the mandibular nerve, and going down into the extracranial compartment. So this is the extracranial compartment of extracranial part of the trigeminal schwannomas. So we saw the meninges, the first lateral aspect, the interdural layer, and then what happens inside the cavernous sinus. So this one, the cavernous hemangioma of the cavernous sinus, is actually a proper tumor of the cavernous sinus. And it is the most benign tumor in the brain, and it is the most vascular tumor of the brain. So this requires a lot of advanced surgical skills to approach this tumor surgically. But if you remove these tumors, then you are actually curing this patient of this disease. So this, you have to understand how the artery is displaced. And this is an angiogram where you see that there is no supply from the artery. You don't see a cavernous angioma on an angiogram. But when you operate on these patients, there is generally a small vessel that comes from the cavernous carotid, and it can easily be coagulated when you are operating. So they have characteristic anatomical relationships. They grow, as you see how the venous sinus of the cavernous sinus are. So they grow towards the sella, they grow towards the posterior fossa. This is a very characteristic configuration of cavernous hemangioma of the cavernous sinus. And here you can see the pre-op and post-operative images. So this is a recent paper on the subject. And I think this is one of the largest series in the world of cavernous hemangioma of the cavernous sinus. Then coming to the other content of the cavernous sinus, and that is the carotid artery. So this one, now you can see the earlier, they had to do surgical approaches to reach this cavernous sinus. Now, most of these tumors, most of these lesions of the cavernous carotid can be managed endovascularly. So this is a traumatic pseudoaneurysm of the internal carotid artery. So this was treated by us using a few coils and a flow diverter in the region. And you see, this is the delayed image, and the aneurysm has gone from the circulation. This is a huge aneurysm of the cavernous carotid, but here you see that there is a cross flow from the other side. So all had to be done was ligate the carotid artery and take care of the aneurysm. This is again another cavernous IC aneurysm where there was no cross flow. And this was actually a growing giant aneurysm of the cavernous sinus. Within a period of 3 months, it grew. The patient initially refused treatment because of the risk but ultimately she came back to us because she developed some hemiparesis. And what we did is treated her with a high flow ECIC bypass with a radial artery and then ligated the parent artery. So these are very old images. We don't do this kind of treatment anymore because there is a very beautiful treatment available for aneurysms of the cavernous carotid, and that is the flow diverter. So this is how you should treat cavernous carotid aneurysms now in this era. And you see this aneurysm and you just pass this flow diverter, and you see here, you can see the stent in this image. Here, this is the flow diverter, and this is a delayed image of the angiogram, and you see that the aneurysm has gone from the circulation. So immediately after you pass in the flow diverter, there is this stasis that you will see on the angiography run. And here you see this aneurysm, and this is a delayed image where you see the artery has reformed and the aneurysm has actually disappeared from the circulation. The next tumors that come from the medial aspect, so come from the pituitary and enter into the cavernous sinus, is this pituitary tumors. And here you see that we have, Professor Goel has divided them into 4 grades. So this is grade 1, where it grows superiorly. It does not enter into the cavernous sinus. It just goes in the cellar and grows superiorly. That is grade 1. In grade 2, it enters into the cavernous sinus and encases the carotid, or it may not encase, but it enters into the cavernous sinus. In grade 3, the tumor actually elevates the roof of the cavernous sinus. So now you know where the roof of the cavernous sinus is. So when the extension is towards the roof, that is grade 3. And grade 4 is when it loses respect for the dura and enters into the intracranial compartment. So this, basically this classification tells you that you can approach all the tumors of the pituitary, majority of the tumors from the nasal route. Maybe it is transsphenoidal endonasal route, but most of these tumors can be approached and removed eminently by using this approach. So you see this grade 1 pituitary tumor removed using a transsphenoidal approach. This is again another pituitary tumor, grade 2. Here, majority of the tumor is removed. Some part in the cavernous sinus is left behind. You can safely observe this part of the tumor. If it grows, you can see what is to be done. Grade 2 pituitary tumors. This is grade 3, where there is elevation of the roof of the cavernous sinus. And here you can try and remove some tumor that comes when you enter into the cavernous sinus. When you enter into the sphenoid, into the pituitary tumor, and you go upward, sometimes you can reach this tumor by using a transsphenoidal approach. One of the last tumors is the chordoma that actually comes from the clival bone and then elevates the cavernous sinus superiorly. So here you see the cavernous sinus and its contents are elevated superiorly, and the carotid artery is displaced anteriorly. So this, once you see this kind of picture on radiology, here you see the carotid artery, you have to understand this pathology is a chordoma. So this relation of the internal carotid artery is very important to understand. It helps you in diagnosing the tumors. And this approach is the middle fossa subgastrian ganglion approach to the clival chordomas. Here you can see these tumors, which has been removed by using this approach. So this is just a short video, just to show you the contents of the cavernous sinus. So here you see the V1, V2, and inside you will see the carotid artery. So you see, this is the carotid artery. This one here is the carotid artery. This is the post-resection of a chordoma. And here you can see the entire cavernous carotid anatomy of the cavernous sinus, where you see the V1, the V2, and inside you see the carotid artery. And you will also see the 6th now. I'm not sure if it is there in this video, but which runs lateral to the carotid artery. Sometimes you can use approach clival chordomas by using a supracerebellar approach. And that is also a good approach for some of these tumors which have this huge extension. And in this approach, you preserve the 6th nerve because it comes early on in your view, and you can actually go ahead and use this approach for removing these tumors. So you can see some of these chordomas that have been operated. And I think that covers a lot of pathology of the cavernous sinus and the anatomy. And I hope you have enjoyed. Thank you very much.
Thank you very much, Dr. Abhidha. As usual, very nice presentation and very nice dissections. If anyone have any questions or any comments, please go ahead. Dr. Eduardo, do you have any question, Dr. Abhidha?
I just want to comment. Very nice pictures, Dr. Abhidha Shah. Very nice lecture as well. And I really like the image when you show the meningoepiphyseal trunk coming out from the intracavernous ICA, and how you can deal with them coming from the roof or coming from the lateral aspect, coming from the lateral wall as well, because really some surgeons are able to do these two approaches. I'm not really a cavernous sinus surgeon, but I studied a lot about this region, and so it was a nice image, because you got this from a perspective a little bit superiorly, a little bit from laterally. So to keep this in mind, that it can be reached coming from the roof or coming from the lateral wall as well. Nice pictures.
So some of these dissections have been done by my colleague, Dr. Sukhdeep Jawar, who is also very, interested in the skull base, and we work on this together quite a few times.
That's nice. Very, very talented then.
Yeah, yeah.
You see, there is no questions in the chat. So next week we will have two presentation, same time, next Friday and 25th. As we can see here, we'll have a presentation also by Dr. Eduardo Rebas about the gross anatomy and surface of the brain. And after that, we will have anatomy on craniometric bones and surface anatomy by Dr. Amit Taba. So if there is no more questions, we can conclude today's presentations. And thank you, Dr. Rebas, and thanks, Dr. Abhidha Shah, for this beautiful presentations. And thanks for your cooperation. And see you soon next week, everyone. Thank you.
Thank you.
Frank.
Bye.
Thank
Bye.
you.
Bye, Eduardo. Bye.
Bye, Nabina. Ciao, Narcisa.
Thank you.
Bye, Nargiza.